Now you can. Great.
Yep.
Okay, so thank you very much for inviting me to speak today, APC, in particular. Thanks to a couple of people, so Nick Capaldi and David Buchanan from APC, who've really helped us in our first few cases with Sniper in the UK, particularly with the prostate work. And that's what I'm going to talk about mainly today. I also just want to thank my colleagues at UCLH and at the Royal Free, and my trainee Jakub Kilic, who put a lot of work into getting some of the PAE data together for this presentation. So, what is a Sniper catheter? It is a microcatheter, 2.2 French distally, and it's got a balloon at the end. It looks very similar to an angioplasty balloon, but the difference being that the balloon at the end is very compliant, and the shape therefore conforms to the artery that you're trying to block whilst embolizing or doing an angiogram. It's quite a flexible, quite a pushable catheter, and it comes in lengths. The lengths I use are about the 150 and the 165 centimeter lengths, although it does come in some shorter lengths. Approximately, it's 2.9 French, and it will go through an 038 parent catheter. So my usual setup is the 165 Sniper catheter with a fathom wire, 014 or an 016 fathom wire from Boston, and I'll put that through normally a Merit 038 Berenstein 5 French catheter, 150 length. And then I have lots of working length out the end. Now, the setup of the catheter, because it's a balloon catheter, it's got 2 lumens, and therefore there is an inherent slight kinkability to the catheter. So unlike a normal microcatheter, which you might be able to tie in a knot, you just need to be a little bit careful with this, but it's a pretty neat piece of kit. This thin wall technology allows it to be flexible and pushable, but it means that if you twist it and play with it too much, you will kink it. So my first rule is to say, if you do choose to use the Sniper catheter, is to always make sure that you have a guide wire loaded in the back before you take it out of its holster, and therefore you will never kink it. It's impossible to kink it then. But the mistakes I've made earlier on is trying to pass it to a scrub nurse and then it getting kinked. So that's sort of my one word of warning. The back end of the catheter looks like you would expect with any balloon. It's got a balloon port and a main port, and the other end, breaking my own rule here, taking it out without a wire in it, but the other end, you'll see that there is a very, very low profile balloon, which you can't see at all until it's inflated. And I've got some lovely ultrasound pictures of this in practice, and you can barely see it until you inflate. So I'll put that aside for a minute. And let's talk a little bit about balloon occlusion PAE, so prostate artery embolization, and the results of using the balloon and why people use a balloon. It goes against some of the mantra that we learn about embolization, being that we want to have flow in order to take the particles distally into the tissue that we're trying to cause infarction in. And as my great mentor, who I've just realized is on this talk, taught me, it is all about flow. And I would just like to challenge that. And in the world of balloon occlusion embolization, it is still about flow, but we're re-diverting flow for the reason of making embolization safer and better. And this is a randomized clinical control trial from Lisbon, and this is from Tiago Bilim, who's a wonderful doctor, trained me at the Eurostream course on PAE, excellent interventionist, and worked with the Professor Pisco, who sadly passed away, and they really did a lot of work to get PAE on the European books as a valid treatment for BPH. And he looked at his results of balloon occlusion PAE versus standard PAE with just a straight microcatheter. And what they found, by matching the groups as much as they could, by keeping the embolic size the same, so 300 to 500 micron embospheres, keeping the volume of embolic the same, they found that the main improvement of balloon occlusion PAE using Sniper was to reduce non-target embolization. And how that happens and why that happens, we will talk about in a minute. But it's not that balloon occlusion suddenly makes the prostate melt away. It's not that balloon occlusion saves you hours and gives you more opportunity to give more particles. In my experience, and that is certainly echoed in the published literature, what the balloon occlusion gives you is confidence, and it allows you to treat without that risk of a non-target embolization. If any of you do PAE and you've had a chap with a penile ulcer or a rectal ulcer or a bladder ulcer, you really know it is the worst thing, and you'll do anything to avoid it. And in my experience, since using balloon, I have yet to have a non-target. We've had one non-target embolization in our experience of over 130 patients now, and that was just with a straight catheter early on in my practice. And 5 years ago, I'm a bit better now. But the addition of the balloon gives me that confidence. Quick Sniper user guide. So we've talked about the parent catheter, and this is the sort of the merit performer range that we use. And from the radial access with a 165 Sniper, you've got great reachability. I can even do a penile embolization distally out in the penile arteries if I need to with this setup with a 165 Sniper. So I'm just going to stop showing my slides and focus on looking at the camera just for a minute, because I just want to show you live how I set up the Sniper. So when you unbox it, the first thing you get is a very handy guide on how to prepare it, and this doesn't project very well at all, but it goes through the steps on how to prime it. First thing to do is make sure you properly wet the catheter by flushing the housing, the handbag, and then once you've flushed it properly, you can keep it inside its housing, but you have to prime that balloon lumen, and it is a little bit tricky to do it. So I always make sure it's in its housing to do this so that you don't risk kinking the catheter. You get these two syringes which have got a locking, the big one has a locking mechanism in the handle, and then you have a smaller syringe which is for actually inflating the balloon, and that's just got a quarter of a mil in it, and that one's a 10 mil syringe. You attach a flow switch, and the most important step to start off with is making sure the flow switch works, which this one does, and I then purge that to get rid of any bubbles of air in that flow switch. And I just let a little bubble sort of form a meniscus on the top like that. I connect that to the side arm of the Sniper with the flow switch open, obviously, and I pull back on the syringe, and I've got a 50-50 solution of obviously I've got dye in this, but I would normally have a 50-50 solution of contrast and saline in there, so 300 Omnipaque, for instance. And once I've pulled back, I then turn the handle to lock, and there will be a stream of bubbles coming into the fluid as I purge that air out of the system. I then double purge it by closing the flow switch, removing the syringe. I then unlock, get rid of the air, and then repeat that process. Pull back, lock, and then open the flow switch again. And the last few bubbles you'll see start to come out. And this takes about a minute, and it's worthwhile waiting, because you really will remove any semblance of air in the lumen of the balloon. Now, once you're happy and you've got all of the air out, and as I said, I put a timer on the clock. I actually do this before I've started the case. I've set this up on the table whilst there's no pressure, no stress, no patient in the room. It's just me and my scrub nurse talking through the case. Once a minute's gone by, give that a flick, make sure there's no bubbles coming anymore. I then release the handle, and I just do that by twisting it, and then it gets pulled down by the vacuum. And then I wait another minute as I then replace the air that was in that vacuum chamber with the contrast mixture. And then after a minute's time, you make sure you've held this up. There's a lot of weight on here. It's very easy at this point to kink the catheter. I then, once that's once that's purged through, I then close this flow switch and remove the syringe. In the guidance, it doesn't tell you that you have to close the flow switch, but it makes me feel more confident that I've done that. So now I have the microcatheter ready. I keep the flow switch attached, and I've got the working lumen there for my wire. I can then use it, get into the catheter, catheterize the branch I need to, and now pretend we're in a small branch, and I want to now inflate the balloon. So if I show you the balloon there on the camera, I now use the small syringe like that, and I attach it to the sidearm, open that flow switch. And the principle is you're not trying to inflate it like an angioplasty. You're just trying to get the balloon, it's a latex balloon, to conform to the contour of the vessel that you're trying to partially occlude. And I use the rule that I use one graduation on that syringe at a time. As you can see, there's little graduations. I advance it one graduation and wait. And then I wait a little bit longer. And obviously this is not in a person, and I haven't got the right solution in here, so we might not see the balloon opening up properly, but eventually you'll start to see the balloon opening up. And as you can see there, the balloon is now opened up, and because it's in air, it's opened up like a barrel. But if you have a contrast 50-50 and you've purged this properly, it will open up like a little sausage, and you'll see it on X-ray. Just to go back to my presentation now, and just to show you what that looks like, I've got some examples of some cases that we've used, and I'm going to show you my data of Sniper. So bear with me 1 second. So I go through those steps. Make sure you flush, keep a wire in it, wait for the aspiration, the bubbles to stop, and then double aspirate. Wait that minute that it takes to do that, and then release the plunger and hold upright and hold tight for a minute. So what's our experience of Sniper over the last 18 months since we've had it on the shelf? Well, initially we did the 150 Sniper, and then the 165 came on the market. So some of the cases you'll see are from a femoral approach, and some of them are from a radial. We've done 22 PAEs, 3 penile embolizations for non-ischemic priapism. I've done a geniculate, I've done a bronchial pulmonary artery fistula, I've done a UFI, a fibroid embolization, and I've used it in one case as a temporary occlusion balloon for a patient who was bleeding, and it was the only compliant balloon we had on the shelf. So this is sort of familiar territory for you guys who do PAE. This is a big old adenomatous prostate on MRI, 140 cc. Chap very obstructed with a peak flow rate of 8 mils per second, normals around sort of 15 to 20. And he had quite a lot of post-void residual of 158 and an IPSS, which is a symptom score for prostate symptoms of 19, which is pretty significant. He's getting up a lot at night, almost going into retention. So these are the pictures you get from a PAE. So you can see here the angiogram of the prostate, and this is the parent catheter. In this case, it was the Merit Berenstein, and through that I've placed the Sniper. And this is an angiogram with the Sniper deflated. You can just about see the radiopaque marker on it, and you can see the prostate lighting up quite nicely. There's the wire through it, and that's it with it deflated, and there it's inflated. And you can see just about in that with the DSA, there is just about, you can make out a sausage of the sausage of the balloon just there. Now, if we keep on going through this angio, you will see there just a fluoro image, and it's the same. You can see quite nicely how it's conformed to the shape of the artery. The balloon will inflate to 6 millimeters, but normally prostate arteries are about 3 or 4 millimeters in maximum diameter. So you can see I've managed to embolize quite quickly. And the after I always embolize over about 10 minutes, but after I've embolized, I then do an angiogram with the balloon deflated, and then I practice coil back, so I coil at the end, and that just allows me to have confidence that artery is not going to grow back. So there's my coils going in. I then look at the other side, and I've realized that I've actually probably already treated most of the prostate from the right. So happy days, quite a quick PAE. It took us about 1 hour 10, and the outcomes were pretty phenomenal. This is the infarct in the transition zone, all this black area here on T2. This is a 3-month MRI. And more importantly than that, the actual volume of the prostate is reduced to 83 mils. And his outcome is fantastic. His IPSS has gone down to 5. He's getting up once at night. He's peeing great. He doesn't have to worry what he drinks in the daytime. His post-void residual is still not 0, 80 mils, but less than 100, which is great. And his peak flow rates double at 15, 16. This is another example of a PAE, and this demonstrates 2 really lovely examples of why Sniper really comes into its own. So that last case, the Sniper just allowed me to get the embolic in quicker. There were no shunts or so to reverse. but it just gave me the confidence just to get the embolic in faster and probably more efficiently. This chap had a different story. So he had a large gland as well, 160 cc on MRI, peak flow rate of 9 milliliters per second, and a large post-void residual of 300 mils, and quite significant IPSS of 20. So I want you to look very carefully at this angiogram. On the left-hand side, there is the prostate artery arising off the internal pudendal. Off the internal pudendal. This is a type 1, so it's arising with the superior vesicle, and that tends to be the hardest to cannulate. With the Sniper, actually, it was no problem. We got into that. And I did my first angiogram proximally in the prostate artery. These little wispy branches you're seeing off proximally, these are the seminal vesicle branches. And then this is the prostate down here. Now, I did that angio. I then advanced the Sniper right down to the hilum of the prostate and did another angio with the balloon inflated. And there's the balloon inflated. And I want you to look very carefully in this area as this angiogram plays. What happens? Just flashing there is a branch that seems to go nowhere. I think nothing of it. I carry on my embolization. You will never get a better prostate uptake than that. That looks fantastic. So I finish my embolization when I use 150 micron, and I then do a completion angiogram with the balloon deflated now. That little branch that was filling, but then if I just remind you, filling and then not going anywhere, this little guy here. Now look what happens. Once the prostate's completely full of beads, that then refluxes up to the rectum. And I, for a moment, panicked. But then I realized the principle of the balloon is that it reverses the flow in the shunt. And I've actually been protecting myself from embolizing that rectum all the way through the case by inflating the balloon. I then went past that rectal shunt and I coiled back like I always do, leaving that rectal shunt intact. Having thought one of my 9 lives had been lost there, I then came back to the right-hand side. And on the right side, very similar anatomy. It's another type 1 prostate artery. I came down again with the same Sniper. The balloon, it's quite easy to reuse. It doesn't, it's not like an angioplasty balloon that gets sort of rucked up and things like that. This goes back to 0. Fantastic. Go into the right prostatic artery, do another angiogram. And I think, oh, phew, this is going to be an easy one. And then I see this thing lighting up. What is that? And if any of you have been to any of Professor Mark Little's talks, he always talks about the straight branch through the prostate. Beware of the straight branch through the prostate. And that's what this is. That's a straight branch that goes through and eventually goes down to the penis. And this is a penile shunt here. Not the biggest penile shunt in the world, but do I want to go down through the prostate, causing spasm in the prostate artery to coil that? Well, probably not. So what I did is I inflated our balloon, and there is deflated, and there it is inflated. And as it's barely inflated at all, just with 1 graduation, enough to reverse the flow in that shunt. And there we go, an angiogram. None of that filling at all of the penile shunt, even with quite a lot of pressure. As I embolize now, you'll see 2 lovely things happen. First of all, the prostate fills with beads. And then as I reach the end point of embolization, the tip of the Sniper catheter flicks from one branch into the other, just there. And that just shows how compliant and soft that tip is. And it actually did the job that I otherwise would have had to have done with a wire. And that was just luck. But it just happened to the balloon. When you filled the distal tissue, the whole balloon will slightly bounce back. And that's the sign that you've reached stasis. You'll feel a bit of pressure, and then the balloon will start to bounce in the prostate artery. Because it's a compliant balloon, it doesn't dissect. It just tells you, starts to nod. And in this case, it nodded and the tip flicked into the other branch. It was great. I could finish my embolization and finish with a coil. And this guy is very happy. His prostate's now 70 mils. Okay, not 0, but significantly smaller than 116. He's still got a bit of a median lobe, but he's got this lovely infarct in the left side of the gland, which is going to continue to shrink over the next year. And actually, I called him the other day, and at a year, his IPSS is now consistently 8, which is fantastic. So that's a good improvement. His PVR is still significant, but it's half of what it was before, and his flow rate's a hell of a lot better. So he's very, very happy. And that was peeing 800 mils. So good job. Just to go through the principle of reversal of flow, I thought I was going to draw you a little diagram here. So on the left-hand side, this is just a straight microcatheter embolization. And this is a summary of that last guy's anatomy. So there's the prostate artery there, this is the rectal shunt, and this is the penile shunt. In normal flow, if you were to embolize just with a straight catheter, some of your particles, and most of your particles, would make their way down into the prostate because that is the biggest organ. However, some of the particles will try and make their way up this shunt here into the rectum. But because there's competing flow from that rectal shunt, there would be some backflow and there'll be some forward flow. And the particles would probably yin-yang here. But depending on how hard you push, some of them might actually go on up into the rectum. Probably not significant, but you rue the day when they are significant. Equally with the penile shunt, most of the particles will go up into the prostate, here, here, and here. But some of them might start to sneak through to that penile shunt. Again, there will be competing flow from the internal pudendal in this direction, and therefore the net amount of beads making it into the penis is again probably very small, but could be significant. And as again, if you get that day where you do have a penile shunt, you wish you had done something about it. When you inflate a balloon like Sniper here, the first thing that happens is you stop any inflow into the prostate artery from there. So any flow into the prostate is purely coming from your catheter and reversal of the shunts from the rectal shunt and from the penile shunts. They immediately reverse. So there's blood flow going in this direction. And that creates a negative wall that protects you from having non-target embolization. So the particles then, even if they try and go up here, they'll quickly get pushed back again into the main prostate artery. Once they're in the prostate, if they try and get through here, they'll quickly get pushed up into the prostate. And you effectively causing a little circuit here where all of the particles get trapped within the prostate itself. And that principle protects you from non-target embolization. Now you'll ask, well, what happens when you deflate the balloon? Surely they just all reverse. Well, no, because actually you've blocked up this artery enough so that the flow continues to reverse. And that is also why I coil back. So I leave a coil. In that case, I left a coil there, so that actually that shunt continues to reverse. And that is my interpretation of how the flow reversal works. Now, I'm sure there are much cleverer people out there who've done proper flow dynamics on tumors, etc. But for the prostate, I've seen that happen in quite a number of my cases. Just to continue singing some of the praises of Sniper, this was a chap who had very complicated anatomy, a big old gland, 141 mils, and the poor thing had a balloon actually inflated in the prostate, and he was desperate to get that out. Thankfully, we were able to help him. As some of you notice who do PAE, you know, men are waiting for HOLEPs and TURPs for a long time. Thankfully, those waiting lists are coming down, but working with our surgeons, we're able to help them a bit with that waiting list. So this chap here has got quite a tricky prostate artery, which is this guy here, and that is coming off it's a type 2 coming off after the superior vesicle, but he's also got this branch here, which I call a lollipop branch, and that is coming off the internal pudendal. However, the internal pudendal artery is actually occluded, and here it comes down and then it stops, and you've got where the dotted line is, where you might expect to have seen the internal pudendal. So his penile flow is all coming off the prostatic artery. So there you've got to think, what am I going to do? How am I going to safely treat this guy? Well, I knew if I just treated the prostate artery, even with Sniper, there would be a huge amount of shunting backwards through that LP, that lollipop branch, potentially causing non-target embolization and failure of PAE. So I knew the first thing we had to do was to open up that internal pudendal. And this was one of my senior registrars, Richard, and actually he did this. So I'm going to take the prize, but actually this was his work. So he got that Sniper, almost using it like an angioplasty balloon. He got it through the occluded common penile artery and actually broke back very nicely into the actual common penile artery proper. And there he found the shunt. So this is the shunt there to the penis. And this is the flow up into the prostate. And I promise you, this is his left prostate artery. His left prostate artery proper was completely atrophic, and this guy was quite elderly, and I think it was just atherosclerotic occlusion. But what's interesting is that there is the left prostate supplied by the right penile artery, as well as a right prostate proper, which is number 1 on that screen. So what did we do? We went into that branch and we treated it with Sniper. So we balloon occluded to reduce any risk of reflux into the penis, coiled it off, came back, cannulated the main prostate artery, and there you can see that right prostate artery with the balloon occlusion beautifully showing up the prostate. He did extremely well. His prostate at 3 months shrunk to 59 mils, and actually, if there are any urologists on there, I was quite proud of this almost HOLEP appearance of the adenome. He actually peed those adenomas out, and after that he felt a hell of a lot better. He is extremely happy. His PVR is 23 and his flow rates up to 17, and he's a catheter free. So what are our overall global results? So we've looked at our data for all of our PAEs, and what I would say is the addition of Sniper hasn't dramatically changed much in terms of my IPSS reduction or my mean prostates that I treat, or my median procedural time. However, it gives me in a number of cases a lot more confidence. So number 1, I've been able to use far more numerously been able to use smaller particles, and we found with the smaller particles, 150 micron, etc., I get a better infarct. And in 8 cases, I've been able to use 150 because I've definitely been able to exclude and reverse a shunt. And in 14 cases, I've been able to use 250. And in none of these cases have I not embolized with a particle because I'm worried about a shunt that I haven't properly blocked with a coil, or I couldn't block with a coil. I have seen shunt reversal in 8 cases, where I've actually seen on angiographically reversal of flow in either a rectal or a penile or a bladder shunt. And probably in the rest of the cases, there is going to be a degree of reversal of shunts. We just don't see it angiographically. My median prostate size that I've treated with balloon is 121 grams, which is the same median within 10% that I treat with a straight catheter. And my median prostate volume reduction is 31% at 3 months. However, I would say anecdotally, my volume of infarction is bigger, and me and Jakob are working on that data at the moment, hopefully going to publish that early next year. Our median IPSS reduction at 3 months is the same as we're seeing with straight catheter, so classic PAE of 11 points. And we have yet to get significant enough data to show what it is at a year, but I suspect it will be about the same. And our procedural time is 2 hours and 2 minutes as a median with the balloon occlusion. So you're going to ask me, why do I use balloon occlusion? Well, it gives me a lot more confidence in big prostates. Big prostates tend to have big arteries. They tend to soak up a lot of particles, and you tend to have bigger shunts in them. And you'll see it on the MR more than you'll see it on the CT. And you'll definitely see it on the angio. And if you see shunts on the workup scan, I will almost definitely open a Sniper. And I'll almost certainly open a Sniper if I've got a prostate more than 150 grams. It gives me confidence in embolization. I can confidently use 150 microns and 250 micron and pack them in a bit denser, knowing that I have protected using the beautiful nature of reversal of shunts with flow and getting better infarcts as a result. It also gives me stability, and with a PAE, this is probably less of an issue. But in the 2 next cases I'm going to show you, which are a bit more off the wall, you'll see why stability is such an issue. In a few cases of PAE, you might see with the very, very massive glands, the prostate artery is very short. And you sometimes get these cases where the prostate artery seems to come off and immediately split. And if it's a particularly difficult cannulation, you might not be able to get very much microcatheter in. And in those cases, actually having a balloon there might give you a bit more confidence of stability. But as I said, in PAE, it doesn't tend to be an issue. However, in this case, I really must thank Sniper for coming to my survival and my safety, and thankfully the patient's excellent outcome. This is a young chap with a horrible osteosarcoma met and a fistula between what turned out to be 5 bronchial arteries and an intercostal artery and a pulmonary artery. And there's the fistula there, and there's the sort of tumoral blush. This is I suppose, a malignant Rasmussen's aneurysm, if you want to call it that. And there actually is a pseudoaneurysm of the pulmonary artery here. With the main catheter, you're seeing very rapid flow into the pulmonary arteries and giving me a pulmonary angiogram from the bronchial artery. And I thought, what could I do to help me here? Well, first of all, I've got a young chap coughing up blood, coughing, moving, breathing with a flimsy little cobra flapping around in the breeze there. I want to get a microcatheter that's going to give me a bit more stability. And actually sticking the cobra into that artery and then backing that up with a Sniper, which is there, and there's the balloon inflated on the Sniper there, and there's my cobra. This gave me a bit more stability, and I knew I wasn't going to flip out the artery so easily. With the balloon inflated, so that's with the balloon deflated, well, that's without a balloon at all. Now, shunt, very easy to see. Pseudoaneurysm, easy to see. A lot of flow down the pulmonary artery. Now, with the microcatheter in and a balloon up, suddenly I've isolated the flow in that micro system. So I've got blood from the pulmonary artery now going up and feeding this way because I've reversed the shunt, and I have effectively blocked any risk of reflux of particles this way by placing the balloon. As I continue to, well, as I start to embolize, in this case I just use particles, and then as you can see I've coiled off another branch there, which is what I tend to do in these shunts. As I say tend to do, I've only ever had to do 2 of these thankfully, but as I've embolized, you can see there is that sort of yin-yang as I've got the reversal of the shunt there in the pulmonary artery. As I've reached stasis, the balloon then slips back a little bit as I expect, and I continue to treat. And as I go through, I see more shunts, I inflate the balloon in more places, and actually, eventually, I found the big mama there, and in that case there, I actually coiled it to try and reduce the flow a little bit, inflated the balloon there, just at the confluence of those 2 bronchial arteries, or intercostal supreme and bronchial, and embolized with particles, backed that off with a coil, and actually, amazingly, this guy survived and he went home 5 days later, and it hasn't had hemoptysis since, and that was 3 months ago. And I think this is my penultimate case. This is a case of a geniculate embolization. This is a lady with recurrent hemarthrosis. I did this case with Dr. Ang Noor from UCLH and Richard Hesketh, and thank you for letting me show this case, and it was a great team effort. This lady had recurrent hemarthrosis post a knee replacement for rheumatoid arthritis, and you can see this horrible blush here of the synovium, which again, if you read the Genesis work and the wonderful cadaveric studies in CVIR, you'll learn this anatomy much better than I'm showing it today, but there is a superior lateral genicular artery here feeding that. And this lady was kicking in pain. She was in agony every time the contrast hit her, even with sedation. And actually, this is another case where Sniper really gave me that confidence. Obviously, I've got a big loop there in the catheter. Because of the metal work, I could barely see where I was, but we got out there, inflated the balloon, and I knew that I was going to have that stability. And there's the balloon inflated. I finished the embolization, and we used particles as we normally would. And actually, you can see the difference there in the synovial blush before and after. And at 6 months, she is walking on that. She is no longer having hemarthrosis. She still has a bit of pain, but it was a fantastic success. And as some of you who know me, I do quite a bizarre amount of penile embolization for non-ischemic priapism with my colleague, Dr. Walton at UCLH. And this is a poor chap referred to us for a penile AVM or AV fistula, sorry, from falling onto his bicycle. And the angiogram there, you can see the blush there in the right crus of the corpus cavernosum, and this classic non-ischemic waveform that you get in non-ischemic priapism. And we actually tend to use a combination of ultrasound and X-ray to reduce the X-ray dose. And this was a nice opportunity to use Sniper and see what it looks like under ultrasound. So in this video, you can actually see the Sniper catheter here in the penis, and this is me ultrasounding whilst my colleague is moving the wire. At this point here, we've inflated the balloon, and the balloon is just visible by this little area there where the mouse is. As the video goes through, you can see I give a test injection of saline, which is that blush there, into the sac of the aneurysm, and I start to embolize. And in this case, I've embolized with thrombin, part 2 thrombin from the Tecile set, and you can actually see it beautifully setting the AV fistula there and stopping the blood flow. And what's nice about the Sniper through the penile embolization is that it reverses the flow in the cavernosal artery, so you don't risk distally embolizing in the penis. This guy at 3 months has got totally normal waveforms in his penis, and he's got normal erections. And this was another penile case that we used Sniper in, and I did show this at BSAR if any of you saw my talk on the Friday. But this was a chap with a pseudoaneurysm, this time on the right angiogram, showing a left-sided AV fistula. And this is an example of showing how really flexible that Sniper is. From the wrist, I've got all the way down into the penis. I've crossed the penis at what's known as a transverse root collateral, and I'm in the left cavernosal artery. This is with the balloon deflated. I do an angiogram, and you can see there the fistula lighting up there. So I inflate the balloon, and what's beautiful in this scenario here is as the balloon inflates, it causes a reversal of flow in that cavernosal artery, and the benefit of that is it allows me to control the blood flow distally into the penis, and it reduces the risk of distal infarction of the penile tissues, which can lead to erectile dysfunction later on in the day with these cases. And in a second, I'm sorry, I can't control this very well, but in a second you will see the ultrasound flash up, and it shows and proves the reversal of flow. So here you'll see the reversal of flow, this chap also did very well. He's at 6 months now. He's got normal erections. I'm sorry that hasn't worked quite to plan, but let me see if I can move that out of the way. This is the ultrasound here, which shows that reversal of flow with the balloon inflated. My summary slide that I want to talk to you about is the importance of why we use Sniper. So my take-home messages are, number one, make sure you take time to prime it properly. Keep a wire in it so you don't kink it, and take that 3 minutes to flush, and then aspirate, double aspirate, and prime the balloon chamber. When do you use it? Well, in my opinion, I use it in large prostates. I use it when I know there's going to be a shunt. So, for instance, in the big prostate or in that weird bronchial pulmonary fistula. It gives me confidence in embolization, knowing that I can isolate and reverse shunts, and therefore, in some cases, allows me to have the confidence to use smaller particles. And in those cases of patients who are coughing or moving, and you want a balloon and you want a microcatheter that isn't going to slip out, the balloon gives me that stability. So that is all the slides I have, and I just wanted to open the floor to any questions. I appreciate we're online and therefore people might not want to speak up, but there is a chat box as well that David is manning, and hopefully we'll be able to, you can shout out, or if you have no questions, we'll end the meeting early.
Thanks for that, Conrad. I don't know, can you see the chat box all right as well? Or do you want me to start reading some of these questions out to you?
Oh, here we go. So can the occlusion of the vessel prevent laminar flow and negatively impact the delivery of embolic due to poor forward flow? It's a really good point, and I think it's a sort of a paradigm shift with embolization with the PAE. You're right, you're not getting that forward flow taking the particles in, and you're having to replace that laminar flow with actually pushing the particulate yourself. And therefore, do you risk clogging up the artery more proximally? Well, in my experience, no, Hannah. I think you actually can pack it more into the tissue. I think when you're looking at liver embolization and things like that, there is a bit more evidence on the balloon occlusion. And actually, they found again that they've been able to get more embolic into the tissue, to the point where I've actually approached our focal prostate surgeons, and now I'm getting such great transition zone infarcts. We've started to think about putting in for a small trial feasibility trial to actually look at embolization for TZ tumours and actually see if we can infarct those. But it is a bit of a paradigm shift for us as IRs embolizing. It goes against the principles, and yeah, it's correct what you say. So Charlotte, did he inflate Sniper on the way to get to the occlusion, or did the motor pass through without having to correct the occlusion? We managed it. The Sniper actually went through without. When I said we balloon angioplastied it, what we did is we sort of dotterized it. The Sniper actually could push through the occlusion without inflating the balloon, so we didn't need to actually inflate to get through that occlusion. But it just shows that even with a Fathom 14, the Sniper does have enough push from a radial to get through an occluded vessel. At what point do you classify prostate as large enough to use Sniper? It's my workhorse catheter now, and this is what Tiago taught me. He said he starts with a Sniper, and if he changes to something else, that's what he changes to. Most of the prostates we get referred to are over 150 grams, so I pretty much always use Sniper as my start catheter. As it's pretty obvious, I'm a young consultant. I'm early on in my career. I haven't done thousands of prostates. I've done probably coming up to 65 now, including the one from last week, and therefore my experience of using lots of different catheters is not as great as other people, and therefore I will maybe check back with me in a few years' time, but I really am enjoying using Sniper for the fact that it's given me that confidence. Hi Conrad, once the balloon has been deflated, it's likely that there will be enough some particle migration. How do you avoid this from happening? Yeah, Jamil, great question. It does worry me. So I coil back to prevent that, to almost trap the particles in. I don't think you get this sudden gush of reversal of flow, because remember, the flow within the prostate is actually then blocked up, so it's kind of sealed up. So I don't think you suddenly get a whoosh backwards refluxing the particles. A few particles refluxing we know happens with the data on Lumibead. We saw, particles do fly everywhere, and a few don't matter, but it's better not to know they're there. And I think judicious use of the balloon, inflating it not too close to the hilum of the prostate, embolizing to a point where you have got stasis with that slight bounce of the balloon, waiting, lots of GTN, and I always put the timer on when I start my PAEs, when I start the embolization, and I even if it takes me 10 minutes, including FAF time, I will not embolize shorter than 10 minutes time. And it's something that Richard, Jakob and I are looking at, actually, rushing, you probably get a sooner endpoint, which is a false endpoint. Charlotte, do you also need a straight run of vessels to occlude it successfully? Yes, you can occlude round the corner. I've got some nice cases where it has occluded round the corner, or even at the junction of two vessels. It's very compliant, and it will kind of squidge into the gaps, and it works nicely. And I think the other thing to say is you don't necessarily have to have a 100% seal. It's just enough to prevent that inflow into the artery, and that's enough to reverse the shunts. And you see that angiographically. You could always argue, well, if you just push harder, you're going to reverse. Well, yeah, you're right, but you are working with the natural hemodynamics of the body, and I think it's a nice technique. Okay. I've been talking for 55 minutes. I'm sure you're all sick of my voice. I'll just leave the chat box running and answer anything else that comes up. But just to add that if you have any further questions, I'm very happy for you to reach out on LinkedIn or on my email, which I think I put on my first slide. No, I didn't, but I'll write it here. So that's my email, and feel free to ask me if you've got any questions about PAE. We are hoping to start a course at UCLH in the near future, where we'll have a couple of delegates who can come and watch us do some cases and talk about the whole sort of clinical picture of PAE and where it sits, and how we work with our urologists, and how we've got our own clinic for PAE, and how that is supported by the hospital.
Amazing. Thanks very much, Conrad. Thanks everyone for attending as well. Obviously, we'll keep the chat box running just for another couple of minutes for anyone that has any other questions. This session's also been recorded, so if anyone does want to catch it, I think we'll be posting it on LinkedIn tomorrow with a link to be able to watch that as well. So any questions following that, again, reach out to Conrad or myself, and we'll be able to answer those questions for you. Other than that, thanks very much, guys, and yeah, hope to see you all soon.